Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bower, the editor of GP Online. On the podcast today, I'm joined by our deputy editor, Nick Bostock.
Hello.
And senior reporter, Kimberley Hackett.
Hi everyone.
To talk about some of the key news stories affecting general practice. Coming up, we're talking about how this year's GP contract will affect practice's finances and some of the other key changes after final contract documents were published. We're also looking at how collective action has helped one LMC secure a significant uplift to local enhanced service funding. And we're discussing the results of this year's British Social Attitude Survey, which shows satisfaction with the NHS and general practice has continued to fall. Our good news story this week is about GP practices signing up to become parkrun practices. That's all to come on this episode of Talking General Practice. So Nick, let's talk about the GP contract first. So last week, all of the documentation relating to this year's contract, the 2025-26 contract, was published by NHS England and the government. So let's start with the money. I mean, is there anything new we know about how funding for this year's deal is going to work, or any more analysis about what it means for practices?
A whole slew of documents around the GP contract for the coming financial year have popped up over the last week or so. It's details of directed enhanced services, changes to the quality and outcomes framework and so on. Maybe the most important update for practices is the Statement of Financial Entitlements, the SFE, which spells out how much they'll be paid for various elements of what they do as part of core general practice work. The updated SFE confirmed something the BMA had said previously, but which the government hadn't previously confirmed, which is that global sum payments per weighted patient for general practice will go up to £121.79 in 2025-26. That's an increase of about 8% compared with the previous financial year, and it could rise further if the Doctors and Dentists Pay Review Body, the DDRB, which advises the government on doctors' pay, recommends a pay increase for GPs and practice staff that's higher than the 2.8% built into the current pay deal. And we could see that advice actually within the next month or so, potentially. The updated SFE also clarifies how funding for locum reimbursement that practice can claim for sickness and parental leave cover will increase in the coming financial year. We knew from the end of February that there would be some increases, but we hadn't seen the exact cash details. So there's some quite substantial increases that are meant to correct the fact that these payments have been frozen in some recent years. The value of QOF points, this is the funding practices receive for hitting performance targets in the quality and outcomes framework. That's also risen by about a fiver to £225.49 per point. And the government has also published details of how some previous targets have been permanently scrapped and how the funding is going to be used to push up the thresholds practices have to achieve on targets related to cardiovascular disease. The SFE also confirmed a rise in the fee practices receive for child vaccinations, which we've talked about before. We're going to come on to some wider analysis of what the whole contract package means for GPs in a bit, but there are a couple of points I'll mention now. An accountant I spoke to this week said the headline increase of £9.29 per weighted patient in the global sum payment per weighted patient isn't quite what it seems, because a fee practice pay for opting out of hours responsibility for their patients has stayed the same from last year into this one. So just to explain the background on that briefly, until 2004, all GP practices were responsible for their patients around the clock, 24 hours a day, not just for the core hours of 8 a.m. to 6:30 p.m. So until that time, until 2004, practices had to provide directly or organise cover for their patients. They did that often through arrangements like out-of-hours GP cooperative organisations. But from 2004, they had the chance to opt out of that responsibility, and most of them, perhaps unsurprisingly, did that. And in return, they paid a levy of 4.75% of their global sum income. And because that percentage levy has remained the same in the 2025 contract, part of the global sum rise is eaten into by that levy. So instead of a £9.29 rise, the benefit to most practices is closer to £8.85. So on QOF points as well, I'm told the uplift looks like it only reflects a rise in the number of patients registered with GP. So there's effectively no inflationary uplift on that element of GP funding.
We've also got some more detail on how funding's changing for primary care networks as well, haven't we? What do we know about that? Obviously, there's been some big changes to the Additional Roles Reimbursement Scheme, the ARRS, which we talked about a few weeks ago. But how's funding changed for that scheme and for PCNs more generally?
So when it comes to PCNs, the largest block of funding is for the Additional Roles Reimbursement Scheme, the ARS. At the start of 2024-25, the total ARRS funding pot for that financial year was just over £1.4 billion. And in 2025-26, total ARRS funding is almost £1.7 billion. So the increase is actually around £256 million. So to unpack that a bit, for the second half of 2024-25, the newly elected government announced it would invest an extra £82 million to create 1,000 GP jobs through the ARS. We've talked about that, a number of times on the podcast. And that was a big shift because GPs hadn't previously been included in the ARRS scheme. And that £82 million extra funding for GP ARS jobs has been rolled over into the new financial year. So the £256 million overall increase in 25-26 compared with 24-25 includes that, plus extra funding to cover a whole year rather than just the 6 months that £82 million was for. And then there's a bit more on top. We talked before on the podcast about how in 2025-26, some of the restrictions on which types of eligible staff the funding can be used to recruit have been removed. Just like last year, GPs can only be recruited through the ARS if they qualified within the past 2 years and haven't previously had a substantive job in general practice. But whereas in the second half of 2024-25, PCNs only had that £82 million pot to use for recruiting GPs, while the rest of the funding pot was ring-fenced for a list of other non-GP roles, most of which begin with P, I think. Now the entire funding pot can potentially be used to hire GPs and for the first time practice nurses. So there's another P. In practice, that's not likely to happen anytime soon in terms of using that whole pot to recruit GPs or practice nurses, because actually many PCNs have already spent their full ARRS allocation from last year. So the funding they get from the scheme is already tied up in paying for those staff. So, those salaries are obviously going to continue into 2025-26. So there isn't a sense that this change in the rules is suddenly going to resolve at a stroke problems with the lack of jobs for newly qualified GPs. There are also some changes to other PCN funding. The core money they receive rises by a couple of pence per patient. An enhanced access payment rises by about 50p per patient. And there are some other payments that rise slightly too. The analysis I've had on that from accountants is that overall management funding for PCNs is rising by only about 1%. So GPs in PCN clinical director roles won't see much of an uplift. And capacity and access payments look like they fall marginally per head of population, which possibly reflects a sort of rise in the patient population that hasn't, the funding hasn't gone with that. So PCNs could effectively end up doing more for less.
The other thing that's kind of changed is that the actual amounts that primary care networks can claim back for those ARRS jobs has also increased slightly. Now, there hasn't been a change so far yet to the actual agenda for change pay rates that staff will receive. So presumably that increase in those payments is to cover the on costs, the associated employment costs, and potentially the rise in employers' national insurance contributions, although it doesn't explicitly say that anywhere. That's the maximum amount PCNs can claim back for those roles, but they obviously have to stay within their overall pot of money for the ARS, otherwise they have to find the costs from elsewhere. So, Nick, what does all this mean for practices? You've touched on there a bit about what you've been talking to accountants about. But what does it mean particularly around, the context of the rise in employers' national insurance contributions that come into effect this month? Just to remind everyone, they've risen from 13.8% to 15%, and the threshold of a salary at which they become payable has dropped from £9,100 to £5,000. So this is a big extra cost for practices, isn't it? And the contract uplift has sort of been worked out to account for this, although no one on any side, the government, NHS England or the BMA, will say that explicitly. There's been a lot of talk about cost pressures or business pressures. But despite this rise in contract funding, GPs are still quite worried about what the national insurance changes will mean for their businesses, aren't they?
Yeah, we had some warnings from GPs in the run-up to the government spring budget announcement last month that practices needed more support to cover national insurance costs that kick in from this April. We've said before that the combined impact of the rise in employer national insurance contributions and the minimum wage in the coming financial year could cost practices something like £250 million or more across England. I think there's no question that the funding package on the table for 2025-26 would not have been anything like the size it is if it wasn't intended to balance out those national insurance costs, even if, as you say, that hasn't been said explicitly. But nonetheless, GP organisations, particularly the Doctors Association UK in the past week or two, were calling for general practice to be fully exempted from the national insurance costs and warning that some practices could be forced to close or even forced to make staff redundant if that didn't happen. Clearly, the government has not exempted GP practices, so they will have to cover these extra costs in the coming financial year from the funding uplift delivered through the contract. So what does that mean? I spoke to an experienced specialist medical accountant called Andy Powell this week about what we know about the impact of the contract after all the detail that's come out in the past week or so. And basically, his take is that the impact will vary a lot between practices and that the ARS funding will fall short of what's needed overall. Also because of this national insurance issue, and that could leave GPs with some really tough decisions to make. So he said we need to be clear that the contract deal for the year ahead is better than previous years. We've talked a lot about how previous contracts have left practices without the funding they need to cover rising costs, whether that's for electricity bills or staff pay rises or whatever else. And Andy said this 2025-26 contract will mean that the average practice has enough funding, enough new funding to cover rising costs, including the national insurance rise, the wage uplift they need to pass on to staff, general inflation, and then still have something left over to give partners a pay increase. But the fact is, the funding uplift is being distributed via a funding formula, the Cahill formula, which is widely seen as not being fit for purpose. There'll be 5-figure gaps for average size practices in the cash benefit they get from the uplift delivered through the formula. And because the funding formula is flawed, those gaps won't match up with variation in workload or, for example, staff costs. So practices that do less well under the formula and practices with higher staff costs are going to fare worse under this deal. And then practices that receive a large chunk of income from non-core funding, so stuff other than the global sum, things like dispensing, local enhanced services, those elements of income won't necessarily increase, so those practices could see a shortfall. The Dispensing Doctors Association, and that's the organisation that represents dispensing practices across the UK, has said this week that some dispensing practices are already considering giving up dispensing because there's been zero uplift to the funding that they receive for that part of their work. So if they're going to continue, they'll have to cross-subsidise this part of their work and the staff that they employ to do that dispensing from their basic general practice income. So to keep dispensing going, they're going to have to divert funding from basic GP services. On the ARS uplift, Andy said that the total uplift doesn't look like it's enough to cover additional costs linked to the rise in employer national insurance contributions. I mean, you talked about the fact that the pay scales have changed slightly, but the total uplift in the amount of funding in the pot for the ARS doesn't look like it's enough to cover the cost of national insurance employer contributions as a whole, according to this specialist medical accountant. And that means that practices and PCNs could be forced to choose between either not uplifting rates of pay for staff they employ through the ARS to the full level they'd like to, or reducing staffing. They could also find themselves unable to afford to use ARS money as it's intended to be to bring in additional GP roles or practice nurses. These are the new roles that have been added into the ARS from this coming year. Because obviously if they try and cover the national insurance costs and the pay increases for existing staff, there may not be a great deal left, is the sense of that. So there's also the risk that practices could come under pressure, and we've seen this in the past, to top up ARS funding from their own income. So overall, the take from an expert medical accountant is that the figures we have so far confirm the sense that GPs had from the start that this contract will probably stop the rot for most practices, but it's really just a first step. And just one final point on this is that the headline global sum uplift the BMA has suggested will come from this contract. It's talked about global sum funding rising by £743 million. That doesn't seem to match up with the £121.79 per weighted patient figure for the coming financial year that's meant to deliver that total uplift. And so Andy Powell said the details on that element of the contract are still opaque, and he said there's basically a need for a bit more transparency so that GPs know exactly where they stand.
That's really good analysis from Andy there, wasn't it? Very good of him to share that with us. So one of the other things we were waiting for more detail on was the new enhanced service for advice and guidance. So the final service specification for that has now been published. Remember, this is the scheme where practices are now going to be paid £20 per request sent under advice and guidance. Advice and guidance means that GPs get advice from a hospital specialist about a particular patient before they actually make a referral. The idea is that more people could potentially be managed in primary care without the need for going to hospital. It's been controversial in recent years because many practices have felt like it's been used as a way to move work out of hospitals and into general practice without any funding to do the work. And some hospital trusts have been quite aggressive in trying to push practices to use these systems rather than allowing GPs to just make a referral. People probably remember this idea was first mentioned as part of the government's elective care plan at the start of this year. £80 million is being transferred from hospitals' elective care budgets to fund this new enhanced service. And the overall aim is to double the number of requests submitted through advice and guidance from 2.4 million last year up to 4 million a year, and to cut 800,000 hospital referrals every year. In terms of the details we now know, firstly, it's been made clear that the scheme covers all clinical specialties and all clinical conditions. It's also been explained that practices will be paid that £20 for one episode of care. And what that means is that they will only be able to claim one lot of £20 for the same clinical issue, even if they need to go back to the consultant and ask another question about the same thing. You know, there are quite a few question marks over whether that £20 is really sufficient to cover the work that this might involve, to be honest. I think we've discussed on the podcast before as well that spending on this enhanced service could be capped by integrated care boards, and the service specification confirms that. So each ICB will get a share of that £80 million funding I mentioned, and then they are allowed to cap the number of requests that each practice can make to ensure that they stay within that limit. And those caps can be applied either monthly, quarterly or annually. And I think there is a bit of concern about how those caps might work in practice and what on earth's going to happen if practices hit those caps very early on. In an NHS England webinar last month, the Director of Primary Care and Community Services, Dr. Amanda Doyle, suggested that some ICBs might want to actually spend more than their share of that £80 million on this and may not have caps at all, but it remains to be seen whether that happens. I think NHS England will be keeping quite a close eye on this and how it's working. They've previously said there'll be a detailed evaluation of how things are going on with this enhanced service early on in this financial year to make sure it's delivering what it's intended to. And what they'll be hoping to see, I suppose, is that the number of requests through advice and guidance is going up, and perhaps more importantly from their point of view, that there's some sign that maybe the number of referrals is going down as a result of that. I mean, there's also been some further guidance specifically for ICBs issued this week on advice and guidance, which you looked at, Nick, and that explains how this is all going to work from their perspective. What did that have to say? Yeah,
so as you mentioned, this advice and guidance enhanced service kicks in this year, offering GPs £20 per request through this system. And we got a bit more detail this week about how that will work and how it'll fit in with the wider plans to sort of bring down the NHS waiting list. The detail came in an operational delivery framework for advice and guidance published by NHS England. And that basically says that each ICB will be expected to set up something called an interface group with joint leadership from primary and secondary care. And they're basically to coordinate how advice and guidance works across that hospital GP boundary. This framework mentions training for GPs around patient choice, some plans around data they want to collect to show sort of how advice and guidance is working. And all of that is part of making sure from the government's point of view that it delivers what they've said. I mean, that's what you talked about, the 800,000 referrals a year increase and so on. A GP I spoke to about this said the interface groups as a concept sound like a good idea to make sure that GPs have a really strong voice in terms of shaping how advice and guidance works over the coming year. But his big concern was that it has to avoid becoming something that dumps a load of new box-ticking requirements on general practice. We've talked before about concerns that the £20 per request for GPs may not be enough to cover the workload. And the sense from this conversation was that limiting the admin demands and trying to make this more about restoring useful channels of communication that sort of used to exist perhaps more in the past between hospital doctors and GPs will be a really big part of defining whether GPs see the new direct enhanced service as a success and something that's helpful.
So staying on the subject of contracts, let's talk about local enhanced services, or locally negotiated services as they're sometimes called. If anyone listening doesn't know what these are services provided by GP practices that are negotiated locally. So they are over and above core general practice. And integrated care boards effectively contract GP practices to provide these services and pay them accordingly for the work that they do. We've talked about them a lot on the podcast over the past year because they've been a key part of collective action, with the BMA encouraging practices to serve notice on any unfunded work they are doing or any services that they feel they're not being paid appropriately to deliver. Kimberley, you've written a story this week about one area that's seen some real success in getting a funding uplift for the local enhanced services their practices deliver. It's really good news for these practices, isn't it?
Yes, it is. So Humber and North Yorkshire ICB has nearly tripled its funding for locally enhanced services. That's LESs to £16 million, up from £6 million. Now, this is a really positive story of how two LMCs and an ICB have worked together to ensure that GP practices have access to fairer funding. So this time last year, 42 LESs were carried out by practices across the area, and total funding for these services came to just £6 million. Some of these LESs were underfunded, and others, such as spirometry and phenotesting, weren't funded at all. This setup hadn't actually been reviewed for 10 years, so at the start of summer in 2024, Humberside LMCs, your LMC and the ICB went into negotiations to review the services. And after months of talks, it was agreed that between the three parties that the 42 LESs would be scrapped, and instead practices would have the option to sign up to providing 10 services provided through 8 LES agreements.
Yeah, you've mentioned some of the services that they were concerned weren't being paid for, but what sort of services are we talking about here? What are the practices doing?
So the 8 LESs cover anticoagulation, PSA monitoring, vaginal pessary for pelvic organ prolapse, wound care, intrauterine system insertion and removal, diabetes, shared care and diagnostic. That includes phlebotomy as well as ECG. So the 42 LESs have either been covered in the new LESs, and others were actually already being covered in the core contract.
Yeah, I mentioned collective action earlier. The LMCs that you mentioned there, they say that collective action has been really crucial in getting this uplift in funding, didn't they? What did they actually say about that?
So when I spoke to Dr. Zoe Norris, who is the medical director of Humberside LMCs, she told me that negotiations were actually accelerated when collective action began on 1st of August, because many of the GP practices served 3 months' notice on the underfunded LESs, and in some cases immediately stopped providing additional services that were being carried out for free. So come November 2024, there was a gap in services, and it meant that the ICB and the LMCs had to work together to commission a new set of LESs. And this cash injection of an extra £10 million is really important because it comes at a time when the government's ambitions to shift services from secondary care into the community so that patients have access to care closer to home.
These aren't the only LMCs that will be having these discussions with ICBs about local enhanced services. As you say there, Kimberley, I mean, like local enhanced services and locally negotiated services are a real way that ICBs can sort of start to get to grips with moving some services out of hospitals and into the community. This example's a pretty big win in terms of the levels of funding involved, but I think other LMCs are also having success on this as well, either getting increased levels of funding or even handing back contracts that have a lot of work involved for practices but not enough funding to cover them. When this year's contract deal was announced, the BMA said it was obviously no longer in dispute with the government and was standing down collective action at a national level. But it was pretty clear that what it called local commissioning gaps still needed to be addressed. And what they're talking about there is unfunded or underfunded work that practices are doing. So while there is no national dispute, the BMA, I think, is certainly hoping that LMCs will continue to be pushing locally for increased funding to ensure practices are being paid appropriately for the work they're doing. Nick was talking earlier about GP contract funding uplift, and obviously those uplifts we were talking about apply to core funding, but we know that local enhanced services now make up a significant amount of practice income. In many cases, they're worth more than the QOF to an average practice. So while those core funding payments that we were talking about earlier have been uplifted for this year's contract, that's not necessarily true for the payments practices will be getting for these local services that they agree with the Integrated Care Board. And while some ICBs may uplift payments to cover practices' additional costs this year, others probably won't. Some practices will actually use the funding they get from local enhanced services to maybe fund or pay for extra staff, often the staff they need to actually deliver those services. And the costs for those staff will be rising this month because of the national insurance increases. The increase in funding for the GP contract overall, as Nick was explaining, that doesn't factor in those staff costs if they're being paid out of this local enhanced service funding. So, the cost for practices to deliver these local services has increased. Will the payments they get from ICBs also increase? That's certainly not a given, and I'm sure LMCs will be talking to commissioners about this in the coming weeks and months if they're not. We also know there's massive variation in the amount of funding practices get for a lot of these services in different parts of the country. Some of that variation is to do with what practices are actually asked to deliver as part of this service, but in many cases there's no reason why the funding is so massively different. In some areas practices are providing things for free, as some of them were in Humberside and North Yorkshire, like you mentioned, Kimberley, when practices are being paid in other areas for doing exactly the same thing. And I think that's probably something the BMA will want to look at in negotiations for a massive overhaul of the contract, which we talked about last time. I'm sure that they'll be looking for some sort of standardisation of the rates paid to practices for these local services. This big contract overhaul that we're expecting in the next couple of years might be a real opportunity to sort some of these problems out. But I guess in the shorter term, collective action, or what was being done under collective action in the form of threatening to serve notice on work that practices are not being paid appropriately to deliver, has clearly proved really successful. So I imagine that's something many LMCs will be continuing with. So moving on, this week saw the publication of the annual British Social Attitudes Survey, which looks at the public's satisfaction with the NHS and social care. The results from the survey are analysed each year by two leading health think tanks, the Nuffield Trust and the King's Fund. Nick, you always look at this survey, you look at it every year. What did this survey find overall, and what did it have to say about general practice?
The two main things we always look at from this survey, and it's a real institution, by the way, it's been running for more than 40 years. I haven't been doing it every year for 40 years, just to be clear about that. What it says about public satisfaction with the NHS as a whole, and then about public satisfaction with general practice. And the findings from the British Social Attitudes Survey have been really bleak on both of those fronts in the past few years, particularly sort of since the pandemic. These latest results of 2024, the polling was carried out in September and October last year, and it shows that only 21% of people are satisfied with the NHS overall, and that's down from 24% the year before. Both of those figures are record lows. They're basically way out of whack with the findings over the past few decades. Satisfaction was 39 percentage points higher just before the pandemic. And in 2010, at the end of the last Labour government's time in office, it was at nearly 70%, so 50 percentage points above where it is now. The picture for general practice, according to this survey, is similar. 31% of people were satisfied with general practice, according to the BSA, in 2024, and that's down from 34% the previous year. But before 2020, satisfaction had never dropped below 60% with general practice. There's also a question about satisfaction with the time it takes to get a GP appointment in this survey, and just 23% of people said they were satisfied on that front. For A&E waits, satisfaction's even lower at 11%, so all extremely doom and gloomy. And the foreword to the report said the findings show the general public is impatient for change.
So how does the survey get these results? I mean, some of our regular listeners might be a bit confused because on the last news episode, we were talking about a positive turn on patient satisfaction with general practice and access to general practice from the Office for National Statistics monthly survey. Why are these findings so different?
It's a really interesting question, and I think it's something that it's really important for us to get into. Because, as you say, the findings from this survey and things like the ONS Health Insights survey are absolutely poles apart. As you mentioned, we've looked recently at that ONS Health Insights survey and what it shows about satisfaction with access to general practice at the moment. So that survey, carried out monthly, the most recent data came out only a few weeks ago, showed that for tens of thousands of patients who have actually booked a GP appointment in the previous 28 days before they were asked, 91.3% felt the time frame between booking and the appointment taking place was reasonable. Just to compare that back, 21% in this survey said that they were satisfied with the time it takes to book a GP appointment. So a little bit different. The ONS survey also showed that around 3/4 of people say contacting their GP practice is easy, and 3/4 of people who tried to contact their GP practice in the past 28 days said their experience was good overall. And over the past 8 months, this survey's been running for, there have been improvements across most measures that it looks at. And it's also worth mentioning that the latest National GP Patient Survey, carried out in the first 3 months of last year, before the data from the BSA, showed that around 74% of respondents rated their GP practice good overall. So how is it possible for the ONS survey to show such a positive picture overall, and for this survey to show what appears to be the diametric opposite? So the important thing here is that the BSA question on satisfaction with aspects of NHS services, including the point about how long it takes to access a GP appointment, does not actually consider whether people offering their opinion have any recent experience of using the services they're commenting on. The question asks, from what you have seen or heard, how satisfied or dissatisfied would you say you are with each of the following aspects of the NHS? And then it runs through various options. So I asked the Nuffield Trust about this, and they confirmed that although survey participants are carefully weighted to reflect the British public, they have not necessarily had any recent interaction with the aspect of the NHS that they're commenting on. So the survey reflects public opinion, but not experience. And that's the key difference. It suggests that in the abstract, people have a negative view of the health service and general practice performance, but when they actually use it, not so much.
So what have GPs had to say about all of this?
I spoke to the Chief Executive of Nottinghamshire LMC, Michael Wright, and he said these findings just shouldn't be taken as an accurate picture of general practice, but that the way they're often reported, without much analysis of the other stats out there, you know, the context that those provide, meant that they really risk undermining morale among GP practice staff and the wider NHS anyway. He felt there was also a risk that the survey findings like this could reinforce exactly the kind of negative public view of the health service that the survey itself reflects. The RCGP also pointed to other surveys that show satisfaction with GP services is actually improving, and the NHS Confederation made the point that the findings maybe aren't too surprising, given that at the exact moment this survey was being carried out, the new Labour government was describing the NHS as broken and talking about how huge the NHS waiting list it had inherited was.
The media, how they write about the NHS, the media more widely, obviously has a massive impact on what people think about the NHS if they don't have any personal experience of using it. I mean, did the government have anything to say about it? Obviously, some of these findings will relate to before this government took office, but what was its view on all of this?
Well, I must admit, I sort of hoped that the government might step in and say something about the fact that more up-to-date and detailed survey findings on patients' actual experience of general practice show a much more positive picture. And I kind of asked questions to prompt them in that direction. But the comment from Wes Streeting was just that the British Social Attitude Survey showed that patients agreed with the government's analysis, that it had inherited a broken NHS. And he also touched on one of the other findings from the survey, and this is more positive, about the fact that the vast majority of people support the founding principles of the NHS and the idea of a tax-funded service free at the point of use. And he said that the government would fix the NHS to make it fit for the future. Interestingly, he didn't mention the fact that the survey also found most people think the government spends too little on the NHS, so we might have to wait for the 10-year plan to see if he does anything about that.
Before we go, we've just got time for our regular good news slot, and this week it's about parkrun practices. Kimberley, this is something you covered. What's going on here?
Wellspring Medical Practice in Killingworth, North Tyneside has become the 2000th practice to sign up to the RCGP Parkrun scheme. Parkrun is a free event for people of all levels and takes place on Saturday mornings across the UK. The RCGP collaborated with Parkrun UK to promote health and well-being for staff and patients, and it's part of the RCGP's wider efforts to promote prevention for health, which is a clinical priority for the organisation. The RCGP said it's a significant landmark for the 2000th practice to have signed up to become a parkrun practice, and it shows that GP teams are being proactive in encouraging their patients to improve their overall health through lifestyle changes. So when practices sign up to become an RCGP parkrun practice, they will have access to physical and digital promotional materials, including a certificate, posters and flyers to display in their waiting rooms. And they will also have access to learning resources and toolkits offering guidance on how to initiate conversations with patients about the health benefits of regular physical activity.
Parkrun's definitely something the college are really into supporting. I mean, I remember when I was at the RCGP annual conference at the end of last year, there was a little video about parkrun practices, and it was one of those things that warms the cockles of your heart, really. It was all very positive and really lovely to see the way that patients and actually GPs were interacting with each other. So, it's a great little scheme, that. Well, that's it for this week. Thanks so much to Kimberley and Nick, and thanks for listening. I'll be back next week when I'm speaking to Professor Naomi Allen, who's the Chief Scientist for UK Biobank, about the work that UK Biobank does and how research using the data it holds could change the face of medicine in the future. So please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access lots of other resources and information on our website at GPonline.com.